Improving Indian polyvalent antivenom, a strategy to reduce snakebite deaths in India. The Million Death Study reported that there were 58,000 snakebite deaths every year in India between 2010 and 2019. It is our responsibility to ensure that no person in India dies of snakebite. There are two strategies to do this: public education to prevent snakebite and rapid administration of an adequate dose of safe and effective antivenom in patients who have been envenomated. The Indian polyvalent antivenom consists of fragmented immunoglobulins FAB2 concentrated from plasma of horses that have been hyperimmunized with venom of the big four species. Antivenom is a problematic biological agent. The focus of this talk will be on the problems of antivenom, efficacy, and toxicity, and how to improve snake antivenom. A 30-year-old man was referred for a hemotoxic bite. His 20 WBCT was still positive 6 hours after administration of 10 vials of antivenom in a government hospital. When he was referred to CMC, he was having melena, 20 WBCT was positive, PT, APTT prolonged, platelet count of 70,000, and fibrinogen was low. This patient had hemotoxic envenomation due to Russell's viper or saw-scale viper. Why was the initial dose of antivenom inadequate? And what are the reasons for variable effectiveness of Indian polyvalent antivenom? The company insert states that 1 vial of antivenom will neutralize 6 milligrams of Russell's viper venom. This is based on the effective dose 50 or ED50 studies in animals. The dose of antivenom, which prevents death of 50% of animals injected with a lethal dose of venom. The average venom injected by a bite of Daboia siamensis is 63 milligrams. Therefore, the dose of antivenom for Russell's viper is 10 vials. The problems with this calculation are that 50% of bites may inject more than 60 milligrams, and studies of Russell's viper in India show that the dose injected may be up to 200 milligrams. Efficacy studies based on ED50 may not translate to clinical effectiveness in patients. In a clinical audit of Russell's viper envenomation at CMC, 73% of patients initially administered 10 vials prior to admission to CMC had deranged clotting test at presentation to CMC, and 45% had AKI, and about 18.9% had thrombotic microangiopathy. All this informs us that 10 vials of Indian polyvalent antivenom may not be adequate to neutralize envenomation in Russell's viper. What then is the optimum initial dose? We do not know the answer to the question, as there has not been appropriate dose-finding studies. 5 clinical trials of antivenom in India comparing different doses did not provide prior preclinical studies to determine the antivenom dose. These trials suffered from problems of design and sample size and do not provide evidence to guide initial dose. The conduct of dose-finding studies of antivenom is an urgent research priority. What are the reasons for ineffectiveness of antivenom? Lower efficacy has been reported. There was a sudden increase in snakebite mortality in 2014 in Government Fellow Medical College, which declined with the withdrawal of a particular batch of antivenom. The antivenom batch had low antibody titer reflecting quality control issues. There is geographical variability of venom composition that has been documented with Indian cobra and Russell's viper. The only source of venom is from the Irula cooperative in Mamallapuram. Indian polyvalent antivenom varies in its efficacy against venoms from other regions. Certain toxicities cannot be reversed by antivenom. Antivenom can reverse coagulopathy and can prevent AKI, but antivenom cannot reverse AKI, muscle injury, and presynaptic neurotoxicity. An adequate initial dose of antivenom may be necessary to prevent organ toxicity. Antivenom may lack appropriate protective antibody against low molecular weight venom proteins that cause toxicity. The second case is a 64-year-old lady with IHT who was bitten on the ankle. She developed hemotoxic envenomation. In the government hospital, she developed generalized urticarial eruptions after antivenom infusion with 5 vials, and she was referred. At CMC, her 20 WBCT was positive. She developed shock and bradycardia on initiation of antivenom infusion despite prophylactic adrenaline, hydrocortisone, and chlorpheniramine. She required adrenaline infusion, following which she was able to complete the antivenom dose. What is the mechanism of antivenom anaphylaxis and how can it be prevented? Indian studies show that 6 to 60% of patients developed antivenom reactions, of which 10 to 15% are moderate to severe. In a clinical trial in Sri Lanka, it was shown that 75% of patients administered Indian antivenom had reactions, nearly half of which were moderate and half were severe. The mechanism underlying antivenom reactions is not clear. The lack of prior exposure to antivenom and poor predictive value of skin tests argues against type 1 hypersensitivity. Studies suggest that the mechanism may be due to complement activation and release of inflammatory mediators. They may be due to non-allergen specific activation of mast cells related to the quality of antivenom preparations. Antivenom reactions are dose-dependent and could be similar to reactions to other macromolecules such as N-acetylcysteine. What is the role of prophylactic adrenaline? A well-designed clinical trial in Sri Lanka showed that low-dose prophylactic adrenaline prior to antivenom reduced severe antivenom reactions by 43% at 1 hour and by 38% up to 48 hours after antivenom administration. This provided high-quality evidence to recommend prophylactic adrenaline at a dose of 0.25 mg subcut before antivenom as a standard of care. So the practice recommendations are to follow the current antivenom dosing guidelines. In hemotoxic snake bites, administer 10 vials of antivenom. If the 20 WBCT is positive at 6 hours after antivenom, or there is continued bleeding within 1 to 2 hours after the initial dose, then repeat another dose of 10 vials of antivenom. In the case of neurotoxic snake bites, administer an initial dose of 10 vials of antivenom. If there is worsening paralysis within 1 hour, repeat another dose of antivenom and administer injection adrenaline 0.25 mg subcut before administration of antivenom. In the concluding part of my talk, I will be discussing about the production of antivenom and the methods to improve it. The different steps of antivenom production are explained in this diagram. Venom is sourced from the Irula cooperative snake farm. Irulas catch snakes from the wild, store them, and then milk them. The venom is immediately freeze-dried and transported to the antivenom manufacturers who maintain horse farms. Horses are immunized with a mixture of venoms with adjuvant serially to raise adequate antibody titers. The horses are bled and the plasma separated. The plasma is then purified or fractionated by pooling and storage, pepsin digestion to make FAB2 fragments, and then precipitated with ammonium sulfate or caprylic acid, then formulated as liquid antivenom or as lyophilized powder. Each batch of antivenom undergoes a series of tests which include purity and potency. There are various problems with antivenom manufacture: the quality of venom, the maintenance of horse farms, the quality of antivenom production, and quality control. The problems with the quality of venom are that there is a single geographical source. Snakes are from the wild. The methods of milking of venom need improvement, and there's a lack of venom standards. The solutions to this are captive breeding of snakes in Serpentaria, the need for regional snakes to be included, improved methods of milking, and venom standards for the country. Other problems include the care of horses and bleeding technique, and improvements are necessary in animal welfare and the use of automated plasmapheresis. Antivenoms also suffer from non-immunoglobulin proteins in the antivenom, and this can be improved by chromatographic separation of the serum. The quality control is also a problem, and manufacturers need to provide venom neutralizing efficacy test ED50 and measures of purity and integrity for every batch. Now, what is the role of the doctor in the antivenom issue? Let us consider the perspective of different players related to antivenom. Antivenom manufacturers have low profit because they primarily sell to the government. Therefore, they have low interest in R&D and ASV improvement. The government lacks focus on snakebite, is not providing information on the scale of snakebite, and has low interest in R&D and ASV improvement. The WHO is advocating for improvements in antivenom by setting standards, providing technical support to countries, and accreditation manufacturers, but they lack the financial resources. The state governments need help in strengthening the health system, particularly at the primary health center and the district hospitals. And medical colleges lack focus on snakebite in training and research. In the midst of all this, the snakebite victims are voiceless. What then can we do? The physician's role in improving antivenom use are to provide good quality clinical care to all snakebite patients. The training of all health professionals, postgraduates, and medical students in your hospital in snakebite management. The audit and documentation of snakebite cases, antivenom dose, and antivenom reactions, and the participation in clinical and treatment research on snakebite, particularly in dose-finding studies and clinical trials. And advocacy with the government for improving antivenom to strengthen the health system to handle snake bites, provide free antivenom for snakebite management in private hospitals and the public health system, to strengthen snake antivenom production and quality control for antivenoms, and to support snakebite research, particularly antivenom development. Thank you.